Hello, my name is Harriet Paul-Teal, and I'm from Boston Children's Hospital and Harvard Medical School, and I look forward to discussing ultrasound evaluation of pediatric abdominal organ transplantation. Ultrasound is critical in the early and late post-transplant evaluation. Pediatric postoperative anatomy and potential complications are not identical to those in adults. Children are more susceptible to vascular complications, and renal transplants in children are more prone to urological complications. What I plan to do with you is to review the ultrasound features and common complications of pediatric renal, hepatic, and multivisceral transplants. Kidney transplantation is the treatment of choice for end-stage renal disease, and both cadaveric and living-related donors are used, and a retroperitoneal surgical approach is done by our surgical colleagues as in adults. But the vascular anastomoses are dictated by the size of the kidney and also of the child. The arterial anastomosis can be to the distal aorta and to the common or external iliac artery, and the venous anastomosis can be to the vena cava, the common iliac or external iliac vein. And the ureteral anastomosis is to the bladder, although the orifice is higher than in the native bladder. And you see here on the right a couple of diagrams showing the anastomoses and the bladder as well. We perform a baseline ultrasound examination within the first 24 to 48 hours after transplantation, and we perform a full grayscale imaging examination where we assess renal size and echogenicity, the status of the collecting system and ureter, and we determine the size and location of postoperative fluid collections. As far as the Doppler examination is concerned, we look for flow in the renal vessels and as well as in the iliac vessels, aorta or IVC and we perform spectral analysis to establish baseline velocities and waveform patterns. And on this slide we have the normal postoperative anatomy of the kidney transplant. You can see here's a portion of the kidney and the main renal artery coming off the aorta in this particular case with the anastomosis right here. And we assess the spectral waveforms. We look for a nice sharp upstroke of the arterial waveform. And we also do assess velocities as well. Here we see normal waveform within the intrarenal portion of the main renal artery, and we also assess venous anatomy, the main renal vein, as well as the iliac vein or IVC, depending on what anastomoses were performed. Complications of renal transplantation can be vascular, urologic. There may be perinephric fluid collections, there may be abnormalities of the renal parenchyma, and biopsy is also associated with complications. Fortunately, the incidence of vascular complications is really quite low, and certainly with the living-related donors, it's extremely low. However, when they do occur, there is often significant morbidity or even graft loss, and it's really important to have timely intervention. So the ultrasound examination becomes critically important, and of course the Doppler evaluation is part of that evaluation. Renal artery stenosis usually occurs within the first 3 months after transplantation and accounts for about 1 to 5% of all cases of post-transplant hypertension. It usually occurs in patients who have undergone end-to-end vascular anastomoses, and a stricture may occur either at the anastomosis itself or within the donor or recipient artery. With color and spectral Doppler, there may be focal color Doppler aliasing, turbulence and spectral broadening. We often see very high peak systolic velocities of greater than 200 centimeters per second at the site of stenosis, and or a ratio of stenotic to pre-stenotic segment velocity greater than 2 to 1. In some patients, downstream of the stenosis, there may be a delayed systolic upstroke and a dampening of the arterial waveform, the so-called tardus parvus waveform. And this, as I say, will be distal to the stenosis and may be seen within the intrarenal arteries as well. If the patients are clinically well, then these patients are generally monitored and treated conservatively. Here's one such patient with renal artery stenosis. Here we see at the site of anastomosis, there's a lot of color aliasing, and I would just mention in passing that it's very important to have the appropriate velocity settings, because if they're set too low, you may have a false sense of a stenotic area if you just look with color, and you must assess this with spectral waveforms as well. And here you can see that the velocity in the iliac vessel is about 98 centimeters per second, but distal to that, within this region of color aliasing, the velocity is very high. It's more than 2.5 meters per second. And you'll notice that the waveform also is abnormal. There's an exaggerated systolic peak and diminished diastolic flow. And more distally within the parenchyma of the kidney itself, you see that there's a small, somewhat delayed systolic upstroke, the so-called tardus parvus waveform. Renal artery thrombosis, fortunately, is a rare event. It occurs in less than 1% of renal transplants, and it tends to occur in the cadaveric grafts and in the young donor kidneys, and usually occurs in the early postoperative period, meaning within the first month after surgery, and unfortunately usually results in graft loss. There are a variety of reasons as to why this occurs: surgical damage to the artery, kinking of the vessel, hyperacute or acute rejection, acute tubular necrosis, or hypercoagulability. And there will be a complete absence of both arterial and venous flow distal to thrombus and in the intrarenal vessels. And it's really important to adjust the technical factors to avoid a false positive examination. And power Doppler may be useful in a technically difficult patient because of its increased sensitivity compared to the conventional color Doppler. So here's one patient with renal artery stenosis. There's no flow within this graft at all, although you can see that we do nicely display flow within the vessels adjacent to the graft. So this was a true case of renal artery thrombosis. Renal vein thrombosis is rare, occurs in fewer than 4% of transplant cases, and usually occurs within the first week after surgery. Patients will present with pain and decreased renal function, and renal vein thrombosis also, unfortunately, usually leads to graft loss. Causes, again, problems with the anastomosis, patient dehydration, hypercoagulability, or propagation of ipsilateral femoral or iliac deep venous thrombosis, or extrinsic compression of the renal vein by a postoperative fluid collection. There will be diminished or absent flow in the main renal vein, and a very important sign of renal vein thrombosis and an early sign is an abnormal elevation of the resistive index within the renal artery. Here is one example of a patient with renal vein thrombosis. The kidney is swollen. There's decreased cortical medullary differentiation. And you'll see in this patient there actually is some flow within the main renal vein. It may be a bit dampened, but it's still there. And in some of these patients, the thromboses actually starts, the thrombosis process begins peripherally, and initially there may be preservation of flow within the main renal vein. And really the most striking abnormality is this flow within the renal artery, which is highly abnormal. You have a very prominent systolic peak and reversal of diastolic flow. This patient went on to have CT of the kidney, and as you can see, it's highly abnormal. There's no minimal enhancement of the parenchyma, really just in the subcapsular region. There's very extensive clot within the renal vein. I'd like to move on now to a discussion of the urological complications. Most of these occur within the first month after transplantation, with urine leak and ureteral obstruction being the most common. Ureteral obstruction occurs in about 2% of cases, often due to ischemia because of the rather tenuous supply to the distal ureter of the graft. There may be edema at the anastomosis. Other causes include infection, extrinsic compression by a fluid collection, or kinking of the ureter. By ultrasound, one can see a dilated collecting system and a dilated ureter, and the site of ureteral obstruction may be visualized as well. So here we see an example of a patient with a urine leak. This is the inferior portion of the graft. There's some dilation of the collecting system, and then we see this anechoic fluid collection surrounding the lower pole. These patients tend to present with ascites and increasing abdominal distension, and ultimately this patient did go on to have a percutaneous nephrostomy and a diagnostic study which showed a leak from the ureter. This is a different patient with ureteral obstruction. The ultrasound image of the graft shows dilation of the collecting system and a dilated tortuous ureter. Percutaneous nephrostogram again shows contrast in the collecting system and ureter, which terminates in this bulbous tip and without free flow of the contrast material into the bladder. Patients can develop urinary tract infections as either an early or a delayed complication of transplantation. And in children, pyelonephritis is relatively common in comparison to adult transplant recipients. And there are also increased rates of vesicoureteral reflux in children compared to adults. So here's one patient with pyelonephritis. We see the kidney and mild to moderate dilation of the collecting system. This patient went on to have a radionuclide cystogram, which we see here on the right. Here's the bladder, and you can appreciate the reflux of the radiopharmaceutical into the somewhat dilated ureter and collecting system. Perinephric fluid collections are very common in the early post-transplant period, up to about 50% of cases. These collections may be hematoma or lymphocele or urine or may be due to an abscess. The ultrasound findings are not specific, and to make a specific diagnosis, fluid aspiration and analysis is required. However, the timing of the development of the fluid collection can suggest the etiology, with hematoma and urinoma generally occurring in the immediate postoperative period, whereas a lymphocele usually has its onset after about 4 to 8 weeks. Here is one example of a hematoma. We have the graft, and in the pelvis we see this somewhat dumbbell-shaped fluid collection with echogenic linear strands. This was a hematoma. And ultrasound, of course, can be used not only for diagnostic purposes, but also to guide drainage. We see here an image taken after placement of a pigtail catheter into the collection. Here's a fluoroscopic image of the tube. This is a patient who had a lymphocele. They are generally anechoic, but they can contain proteinaceous debris. They can hemorrhage as well. And here we see it on a CT scan adjacent to the graft. Parenchymal abnormalities can occur. Diffuse parenchymal disease may lead to graft dysfunction and acute tubular necrosis. Rejection and drug nephrotoxicity are all potential diffuse parenchymal disorders. These are difficult to differentiate by imaging alone. Ultrasound is neither sensitive nor specific for diagnosis, although ultrasound is helpful to exclude other causes of graft dysfunction, and a core needle biopsy is generally necessary for diagnosis. Focal processes, of course, can affect the parenchyma of the graft, and there are many different things that can occur focally: cysts, an abscess, a focal infarct or tumor, and a focal process may not lead to graft dysfunction. Here's one patient with drug toxicity. We see the graft. There's somewhat diminished corticomedullary differentiation. The Doppler ultrasound evaluation of the arterial blood flow is abnormal, but it's a nonspecific finding. We just see that there's very prominent systolic peak and markedly diminished diastolic flow. This is a different patient with acute rejection. Again, we have a swollen graft. In particular, I would draw your attention to the endothelium, which is thickened here. And this is a sagittal view of the upper part of the bladder, which is filled with a small amount of urine, and then the markedly thickened ureter, especially distally. At the ureteroneocystostomy site, we see that there is also urothelial thickening in this patient with acute rejection. Biopsy is performed in the grafts for a variety of reasons and is associated with its own complications, the most important being arteriovenous fistula and pseudoaneurysm. These occur in anywhere between 1% and 8% of transplant biopsies. A fistula will develop when both the arterial and the venous walls are injured by the biopsy needle, and a very large fistula may cause ischemia to the renal parenchyma due to a Steele phenomenon. By ultrasound, we will see a focal area of turbulent flow and aliasing with color Doppler, and there will be very high velocity flow with low resistance in the feeding artery and arterialization of flow in the draining vein. Interestingly, the majority of these fistulas will resolve spontaneously in about 1 to 2 years' time. Here's an example of a fistula. We see the graft, which looks pretty benign, but when we turn on the color, you see this very marked abnormality, very abnormal flow pattern, and then this tissue vibration artifact. And when we analyze the spectral waveform, you'll notice that the arterial signal is very, very fast, more than 5 meters per second, actually, 5.52. When you listen to this in real time, it has a very harsh sound, and this is an arterialized waveform. Again, when you listen to it in real time, you hear that it is it's a venous vessel, but it's arterialized due to the presence of the shunting through the fistula. Pseudoaneurysms are created when an arterial wall is injured by a biopsy needle, and these aneurysms have a cystic appearance by grayscale ultrasound. When they are evaluated with color Doppler, they will display a turbulent, swirling flow pattern. Sometimes it has the so-called yin-yang appearance. A very large pseudoaneurysm is at risk for rupture, and occasionally transcatheter embolization may be required. Here is a patient where we see the graft, and then we have these peripheral cystic areas, and you can see why they might be initially thought to represent pyramids, but they don't really have a pyramidal shape. And when you look with color, you see the very abnormal vascular pattern. And when you interrogate one of them here, for instance, you have a very peculiar abnormal flow pattern. Here's another one, but certainly not a normal arterial or venous waveform. I'd like now to move on to a discussion of pediatric liver transplantation, which is the treatment of choice for end-stage liver disease. And there are a variety of possibilities when it comes to liver transplants. In the larger children, if a whole liver is available, a whole liver graft can be placed into the abdomen, and the IVC anastomoses will occur above the liver and below the liver. The whole graft will contain both supra, intra, and infrahepatic portions of the IVC, and the recipient's suprarenal IVC will be resected, and the donor IVC will be used as a replacement. And then here you see the lower anastomosis, and there'll be end-to-end anastomoses of the portal vein and the common bile duct. And the donor common hepatic artery will be anastomosed end-to-end or end-to-side with the recipient common hepatic artery. In children, we often will come or be asked to evaluate reduced-sized transplants or split livers or living donor transplants, and these are performed because there is an organ shortage, and there are often problems with donor-recipient size discrepancy. This diagram shows a liver split into two portions. The Couineau segments are seen here. And in these patients, the recipient IVC is left intact, and there is a confluence of the hepatic veins in the recipient are formed into a cuff, and they are then anastomosed with the donor hepatic vein or veins using a so-called piggyback technique. The graft can also contain a portion of donor intrahepatic IVC, which is blind ending inferiorly. In my hospital, we perform a baseline study within the first 12 hours of transplantation and every 24 hours thereafter while the patient is in intensive care. We subsequently will follow up with weekly ultrasound evaluations while the patient remains in hospital, or more frequently, essentially whenever clinically indicated. If a vascular problem is suspected, we will supplement the ultrasound examination with CT angiography. MRI and MR cholangiopancreatography are generally reserved for biliary complications, and we use ultrasound as a guidance tool for interventional procedures. So here is an example of a whole liver graft, and I include this image just to point out that in the immediate postoperative period, it is completely expected that there will be edema of the liver, which is manifested as very prominent portal areas. It has a somewhat starry sky appearance, and that appearance should resolve over the next week or two. These color Doppler images are from a different patient, and essentially the arterial and venous waveforms and anatomy are very similar to those that you would expect in a native liver. So here we see a hepatic vein coming into the IVC, and here we have antegrade flow into the portal vein, and here is the left hepatic venous waveform, hepatic arterial waveform with good systolic upstroke and diastolic flow. Here is some normal spectral waveform pattern within the inferior vena cava. Again, with the split liver transplants and the living-related donors and reduced size transplants, the anatomy is often much more complicated and variable. There's a rotation usually of the hepatic segment, so you really need to spend some time to orient yourself. And also, I would just want to emphasize that it's so important to speak with the surgeon, or at least to have a diagram of what the surgical anatomy was at the time of surgery, because that will save you a lot of grief later on and will help you in terms of knowing what anastomoses you are trying to evaluate. So here is a left hepatic lobe graft, and we see the portal vein here, somewhat slightly pulsatile flow, but antegrade flow, the hepatic artery, and hepatofugal flow within the hepatic vein. I'd like to make another comment, and that is that although it's really important to try to search out the anastomoses, and that really is our goal, very often in the immediate postoperative period, they may be very difficult to access because there's often a lot of bowel gas. The patients may be positioned awkwardly. There are usually a lot of overlying bandages. So we try to use whatever window we can, and if we can't image the anastomoses, then we pay a great deal of attention to the quality of the waveforms too, which can give clues about upstream abnormalities. Causes of liver graft dysfunction include vascular stenosis and thrombosis, biliary complications, and rejection. Hepatic artery patency is vital for long-term graft survival and is the sole blood supply to the biliary epithelium of the graft. It's very common to encounter postoperative edema at the anastomosis in the first 72 hours following transplantation. And stenoses have been reported as occurring in up to about 14% of pediatric graft recipients. It is believed to be the most common vascular complication, most frequently occurring at the anastomosis, although it can occur more distally. And risk factors include trauma at the time of surgery and severe rejection. Ultrasound features include an increased velocity, generally greater than 2 meters per second, at the stenotic site, although, as I've mentioned, the site of narrowing may be difficult to identify. And for that reason, you may often end up relying more on abnormal arterial waveforms distal to the stenosis. And as you've seen already in the kidney transplants, we will often encounter a tardus parvus waveform with a decreased resistive index and a prolonged acceleration time distal to an arterial stenosis with turbulent flow distally as well. So here we see proximally near the anastomosis a pretty normal looking arterial waveform, but as we proceed more distally into the liver, we see on the right a pretty dampened arterial waveform, rounded, and an abnormal arterial waveform in the left hepatic artery as well. Hepatic artery thrombosis also is relatively rare, but still occurs in about 5% of the whole liver grafts, and a slightly higher incidence of about 7.2% in split or living-related donor grafts. When there's a complete arterial occlusion, parenchymal infarction with necrosis of bile duct epithelium ensues. There will be an absence of flow in the main hepatic artery, and the tardus parvus pattern will be identified in more distal branches, and they are presumably being supplied by collateral vessels that develop. CT or MRI are often necessary for confirmation of the diagnosis of thrombosis. These patients sometimes are taken immediately to surgery in the hopes of perhaps removing the clot. Sometimes angiography is performed as part of fibrinolytic endovascular therapy. So here's one patient on the day of transplantation, had a study. We see the hepatic artery here in the hilum with a relatively normal waveform, but more distally within the liver, we see that the arterial waveform really looks quite different. It's somewhat dampened, and it has increased diastolic flow, implying that it may be very dilated distal to a site of obstruction. Also note that these additional arterial branches show very abnormal arterial flow. One day later, you see that the arterial waveforms are barely detectable. This patient went on to have an emergency CTA, and you can see that already there's been some damage to the graft. We have these geographic zones of diminished parenchymal enhancement, and the main hepatic artery within the hilum and more distally within the liver is completely occluded. Portal vein stenosis is uncommon and usually occurs at the anastomosis. Patients may be completely asymptomatic, or they may have symptoms of portal hypertension. Portal vein stenosis tends to occur more often in reduced-size grafts because of a limited length of donor portal vein. And various parameters are used to make the diagnosis. There may be more than 50% reduction of vessel lumen or an absolute vessel diameter less than or equal to 2.5 millimeters. As with arterial stenosis, with the venous stenosis, there may be focal color aliasing right at the site of narrowing. The velocity in the stenotic segment tends to be much higher than in the pre-stenotic segment, at least 3 to 4 times higher. And there's often a post-stenotic jet with a velocity somewhere in the range of 1 to 3 meters per second. So here's a patient with a reduced size graft, and you'll notice here is the portal vein, and right at the anastomosis, it's very, very narrow. This is a different patient, but you can see, again, marked narrowing, and there's some aliasing, and then this post-stenotic jet, well documented with the color. And the velocity also is about 4 times higher in the post-anastomotic region compared to just prior to the anastomosis. This patient went on to have an angiographic procedure where you can see before and after where the stenotic area was significantly enlarged. Portal vein thrombosis, again, occurs most often in reduced-size transplant and commonly involves the extrahepatic segment. Risk factors include decreased portal venous inflow. This is often a problem in patients who have many portosystemic shunts, and there's just not a lot of flow going through the portal vein. Prior splenectomy is also a risk factor, and excessive vessel redundancy, and also the use of venous conduits, usually cryopreserved iliac veins. They are also associated with increased risk of thrombosis. Symptomatic cases are treated with thrombolysis or surgery, either thrombectomy or placement of a venous graft. By ultrasound, we see narrowing of the portal vein, and there's often echogenic intraluminal thrombus with no flow. Acute thrombus may be anechoic or may be partial. And reverse portal flow may be seen in the intrahepatic vessels due to the presence of arterial portal shunting. So here we have a patient with a reduced size graft. You see that there is some periportal edema. We can see the hepatic vein here in color and the spectral waveform, which is in the appropriate direction. The hepatic artery, again, appropriate flow into the liver and a relatively normal waveform. But the portal venous flow is very abnormal. We see reversal of flow in the intrahepatic portions of the portal vein. We see it down just to the hilum, but we really do not appreciate the extrahepatic portal vein. So here you see a reversed waveform. And this patient went on to have a CTA, and we see a very large spleen with a lot of portosystemic collaterals, and we really cannot appreciate the extrahepatic portal vein. Stenosis and thrombosis of the IVC are relatively rare, occurring in less than 1% of transplant recipients. These do tend to occur more often in children than in adults, and also in patients who have had more than one transplant. The stenosis may occur due to a discrepancy in the size of the donor and recipient vessels, or there may be supracaval kinking from rotation of the organ. Delayed stenosis may occur as a result of fibrosis, chronic thrombosis, or neointimal hyperplasia. Ultrasound findings include a reduced caliber at the anastomotic site, a velocity in the stenotic segment that is 3 to 4 times greater than in the pre-stenotic segment, color Doppler aliasing, and an absence of the usual flow phasicity that we expect to see in the vena cava. Supracaval stenosis may cause a reverse flow or absent phasicity in the hepatic veins. IVC and hepatic vein stenosis may present as a Budd-Chiari syndrome. IVC thrombosis can occur at the level of the superior and inferior anastomoses and whole liver grafts. And color Doppler shows vessel narrowing or intraluminal echogenic thrombus with no Doppler signal. These stenotic vessels can be treated with balloon angioplasty and stent placement. In this patient, we can see the IVC on the grayscale image. When we look with color, you'll notice that the flow within the IVC, given the interrogation angle, is actually going in the wrong direction. It should be flowing towards the transducer, and it's actually flowing away. And we see this somewhat dampened venous waveform. On this image, we see that there's actual thrombus within the intrahepatic portion of the IVC, and there's a vessel that's posterior to the liver, an azygous vessel, which has enlarged and now contains flow and is taking up the flow that should have been carried by the vena cava in this patient with IVC thrombosis. I'd like to move on now to a discussion of biliary complications. These are the most common complications after pediatric liver transplantation. There may be a leak of bile, or a so-called biloma, that may be related to the anastomosis or maybe non-anastomotic in origin. There may be stenosis of the bile duct with associated dilation, and there may be intrahepatic bile stones, sludge, or debris. Leaks at the biliary anastomosis are associated with very high morbidity and occasionally mortality. When there is a T-tube in place, the leak occurs at the site of T-tube entry into the duct. Non-anastomotic leaks are associated with hepatic artery thrombosis in most cases. The bile can extravasate into the peritoneal cavity, or it may form a perihepatic collection. A small leak may close spontaneously. However, in other cases, surgical revision of the anastomosis may be required, and bile collections can be drained percutaneously. Here's one patient who developed a leak at the site of T-tube insertion. We can appreciate this fluid collection adjacent to the graft, and you can see that there's a dilated tubular avascular structure within the liver corresponding to dilated bile duct, and here we see again the dilated tubular duct and the large bile collection. And here we see the leak at the site of the T-tube insertion. Strictures can also occur at the anastomosis or maybe non-anastomotic. The anastomotic strictures are usually due to scar tissue, and they may cause retraction and narrowing of the common bile duct at the suture site. Non-anastomotic strictures are caused by bile duct ischemia secondary to arterial insufficiency. So again, another complication of arterial thrombosis. So here's a patient with a biliary anastomotic stricture. We see too many tubes within the liver on the grayscale images. This is a vessel, and this is dilated common bile duct and intrahepatic ducts. And these findings are confirmed by MR cholangiography here on the bottom row. Rejection is an important cause of graft loss. There are no specific imaging findings associated with rejection, but as with the kidney, imaging does aid in ruling out other abnormalities, and the diagnosis is only established histologically by percutaneous liver biopsy. I'd like to say a few words about multivisceral transplantation. There are only a few centers that are doing this procedure in children, and my hospital is one of them. They were initially performed in children who had associated or who had simultaneous intestinal and hepatic failure, usually related to TPN cholestasis, so children with short bowel syndrome or pseudoobstruction. But more recently, it has been used successfully as a treatment, albeit a drastic one, of primary abdominal tumors that involve the liver or the root of the mesentery that are refractory to conventional treatment. This is a diagram that illustrates the operative procedure. The stomach, the duodenum, and the pancreas, the small bowel, the liver, and the spleen are all removed from the donor. The right colon may or may not also be removed. And the corresponding recipient organs are also removed. And the donor organs are transferred en bloc to the recipient. The vascular anastomoses are really determined on a case-by-case basis. But amazingly, a common scenario will leave the recipient aorta and IVC intact, and there's only a single aorta to aorta and a single cava to cava piggyback or cava to hepatic vein anastomosis. So only two vascular anastomoses after this very, really sort of heroic procedure is done. The ultrasound imaging of the abdomen and graft anastomoses is performed daily in the immediate postoperative period. And once again, a complete knowledge of the surgical anatomy is truly critical to the success of the examination and the correct identification of complications when they do occur. Probably the most critical vessel to evaluate is the infrarenal abdominal aorta. And when the aortic anastomosis is not visualized, color and spectral Doppler analysis of the hepatic arterial supply can provide evidence of upstream disease, as is the case with liver and kidney transplants when it's difficult to visualize the anastomosis. The evaluation of the venous blood flow and venous anastomoses is the same as with hepatic transplants, and a 4-quadrant evaluation of the bowel is also necessary. Here are some images of the aortic anastomosis. We see the recipient aorta and then the donor aorta here. Here we see it again with color and also on this sagittal CTA, the recipient and the donor aorta here anastomose at this point. Cable anastomosis, as I mentioned, often a piggyback procedure. So here is the donor IVC. It's sewn off inferiorly and piggybacked onto the nape of the recipient's vena cava at this point. And here we can see the kidney and attached to the vena cava. The ultrasound features of the vessel abnormalities, postoperative fluid collections are similar to those of the renal and hepatic transplants that I've already discussed. Bowel disease is very common. There may be rejection, ischemia, infection, or mechanical dysfunction. The ultrasound features of the bowel disease are often nonspecific. There may be diffuse mural thickening, dilation, and or hyperemia, and sclerosing mesenteritis is a long-term complication. Here we just see one example of thick-walled bowel with ultrasound, and there's also some thickening and a mild enhancement of the bowel by CT. PTLD. This is a heterogeneous group of disorders characterized by monoclonal or polyclonal lymphoid proliferation in immunosuppressed patients after solid organ transplantation. And it occurs in anywhere from 1 to 30% of children, depending on the organ and the immunosuppressive regimen that is used, compared to an overall much lower incidence in adults. PTLD is usually of B-cell origin and of non-Hodgkin type. Some cases are T-cell in origin, and up to 95% of cases in children are associated with the Epstein-Barr virus. So PTLD usually occurs within the first year after transplantation in children who are EBV seronegative at the time of transplant and who receive EBV positive grafts. PTLD can occur at any time after transplantation, and there's really a variable appearance depending on the sites of involvement, which may be nodal or extranodal. So here we have a kidney transplant, and you can see on these two grayscale images that there are several solid hypoechoic nodules that are well shown on this coronal reformatted image in this patient with PTLD. Infection is another common problem. It's always a potential threat because of chronic immunosuppression. Infected postoperative collections are readily detected by ultrasound and may be amenable to ultrasound-guided drainage. Opportunistic infections are always a potential long-term consequence, in particular fungal disease. Abdominal ultrasound can be useful in detection of hepatic and splenic fungal disease. For example, microabscesses can be shown, as we see here, although they're often not demonstrated by ultrasound, and if there's strong clinical suspicion, patients may need to go on to have MRI examination. Some places do CT. In summary, imaging plays a vital role in the postoperative care of transplant recipients. Ultrasound with Doppler is the imaging tool of choice for the initial screening of vascular and parenchymal lesions, and familiarity with the ultrasound features of transplant dysfunction will permit prompt diagnosis and treatment of complications. Thank you.